Ngā mihi mahana ki a koto katoa. Thank you, John. Thank you for staying till the end. Do I see tired eyes? Do I see yawning? Perhaps. So we started with Liam with the image that you see before you here. And I think he deliberately took us back to Luke Field's painting in 1887 of the Doctor. And he reminded us of the need to keep the flame of compassion burning. And of course, he also, I felt, Liam, you hark back at many points, and you hark back to Osler. And that lovely quotation with which I was not familiar from 1907 of a calling which exacts from you at every turn self-sacrifice, devotion and tenderness to your fellow human beings. And then the notion of education as a life course, not a college course. And I don't know whether others of you were struck by those reflective questions after the procedure, after the encounter with the patient. Did I listen and explain? Asking yourself that as the patient leaves the room. Was this my decision, or was it a shared decision that we made together? Was I aware even of the most up-to-date evidence? And I loved your expression, the need for the avid use of data. And of course, that is something that Jeff picked up on later in the, Cliff Hughes later in the day picked up on time and time again about are we showing data back to each other? And I'm not going to summarise everything, but we interestingly had Martin Fletcher then talk about what does it mean to be a regulator in this context, and how can we develop regulation in a way that supports professionalism and that meets public expectations about, for example, transparency about your disciplinary record. And Dick Smallwood asked the question, which I will come back to, about how do we find the optimal balance between professionalism and that intrinsic motivation of the individual professional and external regulation. And Bob Maudsley reminded us of the importance of context. And then we had a great discussion at the end of that session. I particularly liked the bit when Liam came in and made the point that I saw time and time again in New Zealand. I know we've seen it in the UK and Australia. The situations where the regulators say, oh, they're not actually bad enough to put any conditions on the practice, but the employer, provider of service knows that they're not yet good enough, that they're not good enough to be practicing in that particular workplace. And then the particularly interesting discussion we had about marketisation in medicine, where it's the only point I agree with everything that Liam said, but I'm not convinced, and I think he would say more in response. I know he would. I'm not clear that we have thought through clearly enough the ethical issues here, both for both the profession itself in terms of our private practices and any number of things. So I think there's some real challenges there. So what is my view on all this? And I'm supposed to somehow reflect the views of the public. So here are some members of the public. They're in fact members of the colleagues at my former organisation, the Health and Disability Commissioner's Office, who, with the consent of a local medical practice in Auckland, are sitting there beneath the Code of Rights. What would the public make of this discussion of professionalism that we had in the first session? Well, I'm reminded of David Blumenthal at Harvard, who says, you know, professionalism can often sound like a refuge of scoundrels. And of course, it's become rather unfashionable. It has connotations of clubbiness. I strongly believe in professionalism. In writing the book that I've been writing, I've become more and more convinced of that, perhaps like Friedson at the end of his life. But we need to recognise that the public, if they were exposed to this discussion, would not necessarily respond in the same way. And interestingly, thinking here now of the tripartite statement, just a reminder that when the Medical Journal of Australia and the New Zealand Medical Journal and their respective medical associations signed on to the American Board of Internal Medicine's new statement of modern or professionalism in the new millennium, there were one or two sceptics, and I know in this country, Kerry Breen wrote, I thought, very, very thoughtfully in the MGA of the need for broader community concerns to be taken into account, and that we needed additional initiatives that will assist the community to trust and value medical professionalism, and that we need to recognise the clear expectation, said Kerry Breen, that these things need to be demonstrated. And we had that as a theme, I think, that was picked up time and time through the day. How do we demonstrate professionalism? How do we demonstrate ongoing competence? I thought that was an outstanding opening session. So then we shifted to the competent professional. I don't even know what my next slides are, but I sort of put them together in a rush. Oh, I put that up because we hear so much about Shipman and about Patel, but here's Roman Hasil, the Slovakian-trained gynecologist who came to New Zealand after a checkered history. Actually, I said he had a checkered history in the media, and I was contacted by the Czech media outlets saying he's not from Czechoslovakia, he's actually from Slovakia. But there were clearly issues of competence for this individual who had a 25% failure rate for his tubal ligations at Whanganui Hospital in New Zealand, North Island, West Coast. But there were communication problems, there was dysfunction in the teams, and there were some health and alcohol issues. So what do we mean by the competent professional? Well, Linda, after showing us the Montreal temperatures, talked to us about the change from the tea steeping model. I lived in Ottawa for 2 years. It's the only time I ever heard people talk about letting the tea steep. But how we're moving from that model, from the sort of old-fashioned model of knowledge base and sort of an acquisition of skills and so forth, to what she referred to as a time-free model, learner-centred curriculum, portfolios of work. And Linda said perhaps we need a middle way here, a flexible curriculum, a hybrid model with timed rotations, visible standards. One of the things I thought that would really resonate with the public from what you said, Linda, was when you talked about competence assured, that the competence of this individual has been assured. And Craig Campbell, as a discussant, talked about the fact that we're very poor at self-assessment, plenty of literature showing this and the need for external standards. And then David Prideaux came in, and I love some of David's slides, but I too love the one of the odd juxtaposition of ENT and lung disease, but this notion that competence is more than the sum of the individual parts, and that lovely slide he used with the composite, the different photographs of the family, and that nice statement that we're not yet to the stage of studio portraits for assessing professionalism. And then we were honoured by a presentation from Justice retired Judge, not retired actually, in some parts of the world, Geoffrey Davies, and the reminder of the notion of professionalism as a public duty, and some pretty hard-hitting comments about unless you demonstrate your professionalism and your service to the public, you're at risk of government control, you're at risk of being turned into a mere service industry, and that this is a collective responsibility. And in answer to an interesting question from David Hillis, the judge said, well, perhaps the problem of these surgeons who get on the money track, that's a real issue. They've neglected their public duties. Does the shame method work? And actually, I thought the judge there said something that would run very well in the, in the Daily Sun or some of the newspapers. I think it's wrong. I think we must resist that. I think what we need to get much better at is sharing information with each other. But he does, however, speak for a view that's out there in the public, saying we want to see all these things. But I'd like to see the evidence that shame works. And then Ian Boma raised some interesting questions about how do we assess the collective, and he talked about how do we take regulators from purely disciplinary bodies to remedial bodies. And actually, I would say that I don't think the public would agree with you, Ian, entirely. I actually think that our regulators have got very, very good at remediation. And I think that if the public really knew actually what's happening in some of our health programs, the way in which matters which actually do raise conduct issues are sent down other tracks, I think there would be public concern. So I think there's a real challenge which the General Medical Council is taking up to become more robust regulators who are more transparent and telling the public, communicating more effectively to the public about what they're doing. But just to close up on competence, of course this matters to the public. Very interesting survey in New Zealand was undertaken in pharmacies to try and get away from the bias of doing it at doctors' surgeries, 2009, 280 customers, 10 different pharmacies. Competence was the #1 attribute. And of course, doctors know that competence matters. There was a book written in 1684 by Fritsch, I can't say it properly, Medicus Peccans. I think it means the sinning doctor, but that can't quite be right. But Medicus Peccans, in which he claimed that the first mortal sin of a physician is to practice medicine without being thoroughly competent in the art. The first mortal sin. So, competence, yes, it matters greatly to the public. I think it's #1. It matters greatly to doctors. I know that both the public, there's plenty of research that shows that, of course, alongside that, we rate the humanistic qualities, the caring qualities that Liam talked about, but competence matters, and we've still got quite a way to go, I believe, particularly in the work that we're doing here and doing in Australia and New Zealand, to model the best work that you see on assessing performance that's coming out of places like the American Board of Internal Medicine. Pause, we're halfway there. So the fit professional was how we started the afternoon. With Karen Plastrier, I loved as others did, the Leonard Cohen, ring the bells that still can ring, forget the perfect offering. There is a crack in everything, that is how the light gets in. I must confess, when I hear a psychiatrist start to talk about boundaries and the need for clear boundaries in a session on fitness, I assume they're going to start talking about sexual boundaries. And I was a little taken aback when Kieran, in one of his little flourishes, referred to the fullest sensual engagement of the learner. And then when he came to describe the clinical encounter, had that rather sensuous painting of a beautiful déshabillé young man. But I put that to one side. He referred a lot to Hadrian. Of course, Hadrian's Wall was the great fortification of the Roman Empire, roughly sort of just below Newcastle across England. Well, it's in ruins if you go and visit there. And it was very interesting to hear Karen's statements. Well, I don't really have a performance boundary, see clear performance boundaries in medicine, but I'm simplifying what was a very complex message, a message that I found quite hard to unpack. I'm not yet sure what he means by disambiguating health and care. I do, however, think that his concept that he harked back to Winnicott, the notion of the good, of good enough medicine, that's certainly something that I think would resonate with the public once they're sort of brought up, once they understand some of these issues that we're talking about, by which I mean that the discussions about professionalism and about competence, especially in the college space, can easily turn into a discussion about excellence. And we're not actually talking about that. We're talking about assurance that any doctor that I may get by chance is going to be one of the 95%, that we don't have the 5% that Liam opened with practicing out there. So that was a really thought-provoking presentation that John Adams then followed with a regulatory perspective and made us think about fitness much more in the traditional health, health context. Are you, and the questions posed by the ageing practitioner. And I love the way Michael Walsh then came in. I know Michael's done so much work looking at inquiries and looking at the role of employers, but the notion of fitness in terms of, am I in shape? Am I fit physically and mentally? Am I appropriate for the role that I'm fulfilling? So have I been properly trained for that? Am I suitable for the place where I'm working? And can I hit the ground running? I think if you talked about fitness for practice in those ways, I'm pretty sure that the public would really resonate with that. I think, however, the public would be completely appalled if they knew, as we all know, the point that Kevin Inray made, that most doctors, well, many doctors do not have their own general practitioner. That's a real challenge still for us, and I think the public would also be shocked to know that we don't have medicals to stay in practice in the same way that people in other industries do. I think they would find that surprising. So a session on, the third session then on fitness, the fit professional, and finally the safe professional. I love that slide, Cliff, of the lighthouse and that extraordinary little, the man and the churning storm and the bicycle, and your fascinating analogy with road safety and with what are the factors that have made a difference in the improvements that we've seen in fatalities on the roads. And you said that we need to let people know just how fast they're going. So often we have no speed limit on our surgeons. And of course in the United Kingdom, led by cardiac surgeon Bruce Keogh and by Ben Bridgewater, they've come out publicly and said, if you don't know how you're doing compared with your colleagues, you've got no right to be doing it. They've published an extraordinary book in March last year, Modern Medical Professionalism, with a very, very strong push on clinicians generating data and publishing that data first to themselves. You've got to build the confidence that you've got robust data, but then sharing it with the public. And lots of wonderful examples that Cliff gave us from both road safety and from surgery, where we know that we're not yet clipping every trip, that we don't say click, clack, front and back, which I've never heard before in New Zealand, but I think it's great. We don't yet say that consistently in surgical practice. And we don't know often where we sit on the blood transfusion graph. And Marilyn Walton with some very interesting comments on what we still need to learn. To be safe clinicians, we need to learn how to supervise for safe practice. And we've now got through the WH framework some great tools to do that. And then we finished with Brendan Crotty's comments on teaching for safe practice. And Brendan, I don't know where you're seated, but you and I see I've just skipped over my good friend Chris Bagley, so apologies for that, Chris. But Brendan started giving us grades. We got a C+ for how we're doing in medical school. I think you were saying a B pass, a C- for pre-vocational training. I think you said we're doing a bit better, about a B for vocational training. And we didn't get a grade at all for college CPD programs, but I got another sense of can do better. So, in closing, just a few comments of my own. At one point, I think somebody sort of said, "Oh well, the public thinks our care stinks." Well, actually, the public doesn't think that our care stinks. The public still has a lot of confidence and trust in their individual doctor, but here, as this survey shows from New Zealand, perhaps not so much trust in doctors in general. These figures are actually somewhat worse than the figures in the UK. And certainly in all our countries, we see this real sense that in our complex systems that we've lost the art of caring. Just in closing, some comments. I've got to put a free plug, and there's a very clear conflict of interest here for my own book, The Good Doctor: What Patients Want. But actually, I've tried to pick up on many of these things. To come back to the question of what's the appropriate balance, I'm not convinced that external regulation and professionalism have to be mutually exclusive. But I recognise the reality, and it's something that's going to be faced by the medical profession here as it is in New Zealand. If you try and make doctors jump through a whole lot of new hoops simply because government says you have to do it, it won't happen. It's not going to work. So you have to do it in a way that supports professionalism, that taps into internal motivation, that makes doctors themselves see that actually this is a better way of continuing my learning than the activity that we're currently measuring. That does it in a way that makes doctors feel, yes, I'm honouring my calling, my service to the public. And I think that's an enormous challenge, but it's a challenge that the public expects us to meet, because the public thinks that we're already doing this stuff. I want to just close, and it is the close. Whoops, I'm going the wrong way. I want to close with the notion of trust, and I want to read you a little poem. And it's a poem by Glenn Cahoon, who is a New Zealand doctor, a general practitioner, and a poet. And it's called A Brief Format to be Used when Consulting with Patients. The patient will talk, the doctor will talk. The doctor will listen while the patient is talking. The patient will listen while the doctor is talking. The patient will think that the doctor knows what the doctor is talking about. The doctor will think that the patient knows what the patient is talking about. The patient will think that the doctor knows what the patient is talking about. The doctor will think that the patient knows what the doctor is talking about. The doctor will be sure, the patient will be sure. The patient will be sure, the doctor will be sure. Shouldn't hurt a bit, should it? I look forward to the day when we can all rely on the public medical register and a current licence to practice as assurance that any licensed doctor is fit, is safe, is competent. People don't want to take potluck. They want to know that every doctor is good enough. And that is the challenge of professionalism for us. Thank you very much.